Welcome to the AA Podcast, our little corner of the web where we are not afraid to discuss tough questions like,
when did nutrition, health, movement, and stress management become alternative medicine?
Where we embrace challenges in all aspects of life to become healthier and stronger versions of ourselves.
And where food and movement are the best kinds of medicine, and cooking meals at home is a revolutionary act. Hello, and welcome back to another episode of the AA Podcast. This is Ashley Olson.
And I'm Andrea Green.
We are going to be discussing a topic I've been blessed with having firsthand experience with, actually secondhand. My husband and my father-in-law deal with this all the time. So I'm excited to get in on this episode. But before we get to all of that, we are going to share our weekly Bible verse, and that is coming from Proverbs 4:23, and it says, "Keep your heart with all vigilance, for from it flow the springs of life."
Okay, and I'm going New Testament this week. So 1 Corinthians 15, 55 through 57. O death, where is your victory? O death, where is your sting? The sting of death is sin, and the power of sin is the law. But thanks be to God who gives us the victory through our Lord Jesus Christ.
Amen. Amen.
Okay.
All right, Andrea. So today we are going to do a 2-part episode on heartburn.
Yes.
And this is such a good one.
Yeah,
I mean, they're all good.
And speaking of, okay, so I still have morning voice, and I'm real sorry, people. I'm not quite the fluffy morning bird that Ashley is. I am a night owl of night owls. So, pardon the morning voice. Part 2 will be much, much better because we'll be recording this afternoon. All right, so heartburn. First of all, I just wanted to get into a little bit like, what is this? Because there is a pathology to it. It can be kind of incidental, meaning, comes and goes. It's not necessarily what we would consider a disease or a condition at that point. So all of us are subject to some heartburn periodically. However, it can progress to the point where it becomes chronic, and at that point we slap another label on it. So what it is essentially is it's oftentimes just a question of mechanics. And so when we look at the stomach, let's just take a walk down the anatomy lane here for a second. So you've got the esophagus, and it's basically a straw that goes down your throat and dumps into the stomach. Well, there's a ringed muscle at the end of the esophagus at the beginning of the stomach, okay? And that all ringed muscles in the body are called sphincters, which makes me giggle a little bit, sphincter. But it's a ringed muscle at the end of the esophagus. Yes, you have one in your rectum too. But we've got sphincters sort of system wide. But this is just one of them. This is called the lower esophageal sphincter, and it dumps into the stomach. And so the stomach is full of like 2 molar hydrochloric acid. And for you chemistry nerds, you will know that is eat your face off acid. Like, that is Indiana Jones skeletonize a cow acid. Okay. So it's big dog acid. So your stomach is really quite a remarkable organ to be able to exist in those conditions. But that's what it takes to break down your food. And there are all kinds of like acid dependent things that happen, and they require that acidic environment in order to happen. Okay, so you've got this pool of acid in your stomach, and if that backs up through that lower esophageal sphincter into the esophagus, then that really irritates those esophageal cells, because remember, this is eat your face off acid, right? And so the esophagus is like, we're dying. We got this acid touching us and we're about to die. So that's why you get that sensation of, oh my gosh, this is terrible. You get that burning feeling. Some people show up in the ER thinking they're having a heart attack because the pain is so bad. So, so that is what heartburn really is, and that is also when we put that pathological label on it. It's called GERD, GERD, or gastroesophageal reflux disorder. So reflux just means that basically reflux is a kind of a term for backwash. So if you have acid that's supposed to be in the stomach and it washes back up through the LES, lower esophageal sphincter, into the esophagus, that's kind of a backwash or a reflux of the acid. Um, and this is like superbly prevalent at any given time. It can be affecting about 20% of adults, and the sad thing is, it's affecting more kids now too, because we're seeing higher rates of obesity in kids, and that's certainly a risk factor for this.
Mm.
So why does this matter? I mean, it's kind of one of those things like diarrhea, where we in the West we have the luxury of being able to kind of laugh and snicker at conditions like diarrhea or heartburn, but there there is an end to the pathology, and it's not good. This can lead to esophageal cancer, and this is a really important principle to know. So I'm going to lay it out, just kind of a brief overview of why esophageal cancer can form. And this is sort of an underlying principle of a lot of cancers, so it bears going into. So the acid washes into the esophagus, all right? So those cells, they're not built for 2 molar hydrochloric acid. They're not built to withstand that. They're not supposed to be in an environment like that. And so the body, in order to protect herself from that acid, if it continually washes into the esophagus, those cells will begin to transform. And if you know anything about cancer, you know the word transform is not a good word, because it normally means normal, regular cells transforming into cancerous cells. So as that acid continues to wash over the esophageal cells, they will transform into a cell type that is more consistent with what we find in the stomach, right? Because those are the cells that are built to handle the acid. Now, if we have cells that are growing where they should not be, which is now what some of these esophageal cells have become, that is a precancerous and can progress into cancer. So this is why we really need to get chronic heartburn under control, because it can lead to esophageal cancer. It can also lead to various other esophageal maladies like Barrett's esophagus, etc. But this is the big one. And so we don't want the body being hurt and healed, hurt and healed, hurt and healed, because anytime that you get that hurt and heal cycle, you run the risk of cancer.
Mm. The only time that is okay is
Muscle. Yes, that's exactly right. That's exactly right. Because you're not transforming the muscle. The body isn't like transforming a muscle cell into something else to protect itself.
right. It's literally repairing with what it is.
Yes, yeah, it's getting that muscle body's getting bigger.
Yeah.
Um yeah. So
So yeah. So what is like kind of the? I mean, I've always been like, oh, you have heartburn, take a Tums. What
mhm.
what is the what is kind of like the layman's term or thought process with heartburn?
Well, the conventional understanding and that has trickled out into the, public knowledge and perception of this is that, oh, you have way too much acid. And so we get this sense of this sort of overflowing stomach pouch of acid. And then it just pushes up like a geyser into the esophagus. That's kind of where our mind goes. But and then so the conventional treatment would be, we need to reduce acid, right? So that you don't have this geyser of eat your face off hydrochloric acid that runs into your esophagus. But as we'll talk about when we get to the functional side of things, that's often not what's going on. So let's begin by talking about some common over-the-counter options, because we will get to the more functional side of this in part 2, and I'm going to go into what is often what is really happening in the stomach, okay? So the
It's kind of like when we were talking about in our autoimmune series, like uh, usually a symptom of what's going on, like say
Mhm,
eczema or whatever,
mhm,
um, is not actually the problem. Like that's not the end all be all. It's a symptom of
right.
what is actually going on
Yeah, no,
deeper down.
that's exactly right. And so if we consider that you know, we don't have the pathology right in sort of conventional think, and although things are starting to change a little bit, the understanding of what's going on, but our treatments remain the same. Conventional think here is, hey, we've got this esophageal pain, we've got this burning. If we can stop that, that's a treatment. Okay, well, um, so in theory, yes, we can get quick relief. And the first thing I'm going to talk about is the use of antacids. And actually, from a functional perspective, I prefer these. These do the least amount of damage. Okay.
So we're talking Tums, Rolaids.
Malox, any of the oxides, any like a calcium oxide, a calcium carbonate, a yeah, baking soda kind of things.
Okay.
So what this is doing is, this is just a very, very simplistic chemical reaction that's happening. So you've got acid, you put a base on it, it neutralizes it, and again, chemistry nerds. Acid plus base equals water and probably some CO2, but I'm harkening back a lot of years for that. But it does create water, and it also neutralizes the pH, because when you have free protons or hydrogen atoms that are running around, hydrogen ions that are running around, that is the purest form of acid. So you want to capture those hydrogens and create H2O with the base that you are putting in, the hydroxides that you're putting into the system. So hydrogen is an H plus a hydroxide, which is an OH. You put those together, you get two H's and an O, right? There you go. It's chemistry 101. So you get water. Um, so
Uh,
this is exactly like, and I don't know how many of you are going to remember. I barely remember this, but apparently, and I'm not a car person, but apparently if you have like a battery acid leakage on your car battery, they used to put sprinkle baking soda onto a car battery to kind of neutralize that acid so you don't burn yourself when you're working on it. And that's the exact same thing that's happening here. Okay.
okay.
But they're also very fleeting in their relief. So they work fast, but they don't work for long periods of time. So that was kind of the downside or the drawback to these kinds of therapies, is that you're constantly taking them throughout the day whenever the heartburn would rear up. Um, so then, gosh, these drugs have probably been around for almost 40 years, but they're called H2 blocker. Actually, maybe longer. The OG was called Zantac, which has been pulled from the market at this point. But H2 blockers came next. And these, so I talked about H. Well, there's another H that is in there, and it's called histamine 2. Okay. So this is truly a histamine blocker. And you might be thinking, hey, why are we talking about histamine? We're talking about stuff in the gut. Well, there is a histamine component to the acid production in the gut. So there are H2 receptors in the cells that line the stomach, and those then, when they're bound by histamine, that special histamine in the gut, they will then produce acid. Okay, so if we can block the histamine from binding its receptor and put a drug there instead, then we can block some of the acid production. Okay, now these are drugs like Pepsid. There used to be one called Axid. There's one called Tagamet. There was one called Zantac, but these go by generic names: famotidine, nizatidine, cimetidine, ranitidine. Okay, so our listeners are probably most familiar with like famotidine and maybe cimetidine, but Pepsid, which is famotidine, that's kind of the one that if we're going to use anything, that's kind of the one we use. Now these went over the counter a lot of years ago. They used to be only prescription, but they went over the counter. Now I want to tell you guys something. These were only ever intended to be used for up to 2 weeks. How many people do you know, Ashley, that have been on these things for years
And taking them daily.
and taking them daily? Yeah. So when you look on the manufacturer's recommendations, the pharma recommendations for these drugs, they'll say 2 weeks. So H2 blockers, the pepsids, they do not completely suppress acid. Okay. They don't completely suppress it. The next class of drugs almost completely suppresses all the acid that you're making. Okay?
Crazy.
Crazy. So, H2 blockers only intended for 2 weeks of use. Now, PPIs, that's the next class of drugs I'm going to talk about. These are
Yes.
called proton pump inhibitors. So, an H plus, that hydrogen ion, an H plus is called a proton. Okay? So, this is a proton pump or an acid pump inhibitor. So,
Which, if you've listened to our cognitive health
mhm.
episodes, this should sound familiar.
It should sound familiar because they can cause dementia over time. We're going to get into that in just a minute, but yeah, they're terrible. They're really terrible. They are also supposed to only be used for 14 days at a time. You are supposed to have a maximum of 3 courses of these per year. I think even that's too much, but
Oh my
yeah,
gosh.
this is a total of 6 weeks per year. That is the absolute max that anyone is supposed to be on these. Okay?
Oh my.
Yeah. So these are the big dogs, and the reason that people use these is because they block so completely. I mean, they just take it all out. All right? So you're not producing any acid. Your body's not able to. Do you think that's a problem?
Mhm.
That's a huge problem. That is a huge problem. So much of our digestive capability occurs as an acid dependent mechanism or a pH dependent mechanism. And so when we talk about pH, the pH in the stomach needs to be low, 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 low. It's got to be acid, acid, acid. The reason for that is because we need to break down food. We also need to keep bad bacteria from growing. Now, are there bacteria in the stomach? Yes, there can be. It's not the sterile environment that we thought it was. The small intestine is not completely sterile like we thought it was. However, it's kind of like those deep ocean vents, right, where you get like this really extreme conditions, and there are some bacteria that actually grow down there. They're called acidophiles. Some of them grow without the presence of light. They grow without oxygen. They grow in these really extreme conditions. Well, there are some bugs that can grow in our extreme conditions of our gut too, but by and large it keeps a lot of the bacteria that we don't want growing there, it keeps them out. So it's a mechanism of not only digestion and then further absorption of nutrients, but it's also a defense mechanism against bacteria and things that, we don't want to be impacted by. So a lot of the things that we eat contain bacteria, and it, think about the last time you had food poisoning.
Mhm.
That bacteria that you ate had to overcome some pretty significant acid in your stomach. And so most of the time, you don't get sick from the bacteria that you eat because
Mhm.
the acid takes care of it. Okay. So,
So
yeah.
if you're so I'm just thinking like, okay, we've reduced the acid in our stomach,
Hmm.
and then therefore now we're probably having other things like
Oh, yeah, we're
diarrhea.
getting to that. Oh my gosh.
Yeah.
Yeah, we're getting to all of that. So the first thing I want to say is, so we talked about the manufacturer's recommendation. Don't be on these things for any longer than 2 weeks, 3 times a year. Okay.
Which, okay, are doctors telling people this? Because I
No.
know for a fact people are on these daily.
Well, and here's the other gotcha. These drugs, so the PPIs that I'm talking about, this is Prilosec.
Mhm.
This is, let's see, esomeprazole, lansoprazole, pantoprazole, or Prevacid, Prilosec. Those are probably the two big ones. There's another one called Nexium, and then I'm drawing a blank on the last one here. But anyway, those are the major ones, and they are over the counter.
Mhm.
So I'm not going to lay this completely at the feet of prescribers, because they will put somebody on something, and maybe they were hoping it would be a short course, but you have to tell people. Now, the other thing is, even if you tell people, they will go and get these from the grocery store,
Right.
and they will
Well,
stay
it's
on
helping
them for
me, so
years.
I don't see a problem.
That's exactly right. That's exactly right. So, studies have shown that people are on proton pump inhibitors for an average of 2 to 5 years, but I would submit that is not recent data, because the people I see, they're on 5, 10, 15 years of these things. It's
Mhm.
terrible. So overprescribing is widespread, and especially in primary care, and when people get discharged from the hospital, they're often sent home on these things. Okay, which they have their place. Don't get me wrong, they have
Right.
their place,
Right.
but we really need to be educating people about the dangers of long-term use. Okay.
Yes.
So now let's talk. You brought this up. Let's talk about some of the things that happen as you're on these for long periods of time. Okay. So the first thing that I want to talk about is just this rampant nutrient malabsorption. So it is we're so exquisitely fine-tuned and designed that the a lot of the enzymes that break down our food, it's this really exquisite process where the enzyme creation, like the folding of the proteins, is dependent upon an acid environment, and it has to be a specific pH before those proteins will fold exactly like they're needed to form the enzymes that then break down the food. So it's when we're monkeying with the acid, both the content and the pH in the stomach, we're really screwing up absorption. So
Mhm.
you also have cells within the stomach that create B12 with a lot of other inputs. They absorb B12, they produce intrinsic factor. It's a whole big thing. But we get B12, like really rampant B12 deficiencies, because of this non acidic environment. All right. So, use of these drugs causes really profound B12 deficiencies, which can then lead to a certain type of anemia. Um, you also get the standard anemia, because I don't know how many of you have talked to your provider about, like, a potential iron deficiency problem, but if you've ever tried to get your iron up, especially if you're a woman, because, we have the obvious monthly blood loss, and so a lot of women are walking around anemic, it's very
Mhm.
difficult to get your iron up. It really is.
Mhm.
It's a fussy little molecule to try and replete. And if you are screwing around with your acid, you better believe that impairs iron absorption too. So there's a
Interesting.
whole lot of anemia that goes along with this. Now, you also, when you are taking a PPI, you can get something. Okay, you can get something called PPI induced hypomagnesemia. All right. So I leave it to us to come up with some ridiculous, right? So you tell somebody, hey, you've got PPI induced hypomagnesemia, and they're like, what? I don't know what that is. Well, basically, what it is, you've been on a PPI for so long that you have magnesium deficiency and your body can't absorb it. And that's a problem that can lead to cardiovascular issues.
But don't worry, we have another pill for that.
Oh my gosh, it makes me insane. So then you've also got calcium malabsorption. Now this is huge. There are
Yeah.
so many women who are walking around
Mm.
osteopenic or osteoporotic because with fractures because they can't absorb calcium because they've been on a PPI or an H2 blocker for
Well,
years.
okay, now they're on PPIs. They've been on birth control for how many decades?
Mhm.
And now
Mhm.
you have this, I mean,
Yep.
among other drugs that you've been on,
Yeah,
and
that's
now
right.
you've had
Well,
brittle bones.
and you also have perimenopausal and menopausal women that aren't receiving hormone replacement therapy because, quote, we don't do that anymore,
Right.
and they don't have the protective effects of estrogen, and so it's just a nightmare situation for osteoporosis and fracture.
Ugh.
So, next up is digestive and microbial issues. So remember, I talked about those, very very few organisms that can survive in the gut, and that's the way it should be. So once you take that acid down to nothing, guess what? All the bacteria from your colon. So there's a process here. There's a process. So you destroy the acid
Mhm.
that destroys your digestion. So things digest intensely slowly, if at all. And so you can imagine your motility. This is your ability to eliminate food. Basically, you're not pooping. So
Mhm.
you become intensely constipated. So,
Mhm.
where do the bacteria from your colon go when they're not going out the other direction? We need that extinction event every day, every single day, because bacterial doubling times, those populations are going crazy, right? 1 billion bacteria, think about that. 1 trillion bacteria. You get a doubling time and now you have 2 trillion bacteria, okay? Then you have 4, then you have 8, then you have 16. So, anyway, bacteria reproduce rather quickly, and so when you don't have that elimination event, you can get into trouble. And so the bacteria then, they begin looking for alternate housing, right? Because there's too many of them, they're crowded. So they start going back up the small intestine because you don't have the acid now, or the digestion, and so then you can end up with something called SIBO, or small intestinal bacterial overgrowth. That is a real bugger to treat. It's a
Yes.
problem. Okay.
Yes.
So you
Wow.
also, because you don't have acid, acid is the first. So there are two types of digestion. I'm trying to think of how deep I want to get into this. There is a mechanical digestion, and then there is a chemical digestion. So the mechanical digestion is from like the turning and swirling of the rugi or the folds in the stomach, okay?
Okay.
So that is like a mechanical process. Then there is this chemical process that happens when we have acid that starts to break things down kind of indiscriminately. And then we have further chemical digestion with enzymes, all right? So all of the chemical digestion is dependent upon the acidity of the gut and protein in particular. So this chronic bloating that people have, these food sensitivities that people have, a lot of times this can be traced back to some form of maldigestion. All right. So you don't get protein, you get chronic stomach upset. You're putting food down there, but the body's like, listen, you've completely tied our hands. We can't do anything with this food. So it sits and it bloats.
So we're talking, I mean, and this goes back to like our history from
Mm-hmm.
childbirth to right, childhood, sorry, not childbirth.
Mm-hmm.
Childhood to adulthood. Like it could be a leading up event to all these issues.
Oh, sure. Yeah. If you've had and it's kind of chicken or the egg, right? Like when people tell me that they had a really anxious childhood, then chances are, especially women, chances are they've either had some constipation or they've had issues with diarrhea. Mainly, it's going to be constipation problems.
Mhm.
And so that can lead to SIBO. SIBO can lead to, heartburn symptoms. Or it can all start with the heartburn and the acid issues, and then you treat it, and then you're off to the races with SIBO. So it's very convoluted, and sometimes it's hard to get back to was it SIBO first, or was it heartburn first, or was it constipation first? Ultimately, sometimes it doesn't matter. You just need to treat the person in front of you and get
Mhm.
that digestion moving again.
Mhm. Okay.
Now here is a real problem. So any of you microbiology geeks out there, when I say Clostridium, that should make you pucker. That makes me pucker when I hear Clostridium. Clostridium is one of the most intensely pathological organisms against humans that exist on the earth. Um, this is botulinum. Okay, botulinum toxin, not Botox. Yes,
Oh,
is
okay.
a
Yeah, yeah. Okay.
it is a Clostridium toxin. However, it's more commonly known as botulism. Okay,
Okay.
so botulism is a Clostridium organism. So that is Clostridium botulinum, and we know that the amount of toxin that will fit on the head of a pin will kill you quick. If you're eating some weird canned food with like a big ol' air bubble, right? If the lid is bulging, don't eat it if it's a canned food, because we're always wondering about botulism or botulinum toxin. Um, so there is another Clostridium uh, bacteria called Clostridium difficile, or C. diff.
Yeah.
Okay, you've heard of that. C. diff, that's Clostridium difficile. It is a Clostridium bug, so highly pathologic to humans. And if you get this can have life-threatening complications. This is diarrhea like you have never had before. It is some of the worst. Ask any nurse. A C. diff patient, oh, that's the room that you want to avoid if at all possible, because it is
Oh.
it is it is just so hard to care for. In fact, the C. diff probabilities are so high that the FDA mandated a black box warning on, I believe it's only PPIs. I'm going to have to check that. But the black box warning says that this puts you at an increased risk for developing a C. diff infection. So that's a big deal. Now, there are also, so we've talked about stuff that's happening in the gastrointestinal system, in the GI tract, right? Let's go outside the GI tract. And I want to talk about systemic impacts of H2 blockers and PPIs for long periods of time. So, this can cause kidney disease. Studies have shown that this causes an increased risk of kidney disease. We have I don't know if you've noticed this, but I want you guys to look around. The next time you're just out driving, look around and see how many dialysis centers there are. DaVita is one of the big ones, okay? But there are these national companies that have dialysis centers absolutely everywhere. Now, 30 years ago, 40 years ago, this was unheard of. Nobody you knew had kidney disease. Now, it's everywhere. People are on dialysis chronically, okay? So, these drugs increase your risk for developing kidney disease. They also increase your risk for developing type 2 diabetes. Okay? They
So
mhm.
kidney disease, could it also lead to kidney cancer?
Um Probably not, but I don't know.
Okay.
I don't know. I don't know a mechanism for that. That's not to say that it couldn't, because I just don't know.
Yeah.
But the mechanical impact on the kidney, yeah, for sure, can cause chronic kidney disease. Um, Also, so we've gone through kidney disease. It will increase your risk for developing type 2 diabetes. It will also increase your risk for developing dementia.
Yeah.
Hmm. Also increases your risk for developing cardiovascular disease. Like this right here, kidney, diabetes, dementia, cardiovascular disease, that's like the trifecta of everything that we call diseases of lifestyle here in the Western world: diabetes, dementia, cardiovascular disease.
Yeah.
Uh,
I mean, it is incredible. Christian and I, we go to a public gym here, and it is incredible. Now, granted, some of these maybe just be nerds that want them, but I've seen several that actually have the pumps.
uh-huh.
But not the amount of diabetic people that
Yeah,
you
and
see
if
nowadays.
they have a pump, that means that they have gone through, generally, because we really don't like prescribing insulin unless someone is a type 1. Ideally, you do not want to prescribe actual insulin, because insulin begets insulin, meaning they really don't get better from that. They get worse.
Mm,
So if somebody's on an insulin pump, they may be a type 1 diabetic, and that is an autoimmune disease, which is also running rampant. Um, but yeah, it could be that they have gone through all of the diabetic medications that we have, and they are now what used to be called a brittle type 2 diabetic.
mm.
But it is an insulin dependent type 2 diabetic. And
Yeah.
yeah, that's a
And
big deal too.
you also know, I mean, a handful of people, I mean, especially in my line of work, I hear about my clients' parents having dementia. We hear about cardiovascular disease.
Hmm.
I mean, it is just crazy.
Yeah. Yeah. And don't get me wrong, PPI use or H2 blocker use is not the genesis of all cardiovascular disease, dementia, and diabetes. However, it's a piece of the puzzle. It certainly
Right.
accounts for some of it.
Yep.
And so, yeah, this is a problem.
Well,
Um,
in my mind, like, it's like, okay, it might not be the culprit of why you have these things,
mhm.
but it, to me, defines your lifestyle
Right.
and why you are even on them in the first
Right.
place.
And there's plenty of room for improvements.
Right.
Yeah. Um, so the final thing that I want to talk about here is this idea of rebound hyperacidity. So the problem is when you withdraw these drugs,
Mm,
that people will get this massive rebound effect. And so acid production then will go crazy once they've discontinued, and that kind of traps them in this cycle.
mhm,
And so you really want somebody who knows what they're doing to help you to get off of these, because it is a process, and it's problematic. And it can take a really long time to get you off of them, just depending on your individual physiology and then also how long you've been on them. But
Mhm.
it can be kind of a hoo-ha to get you off of these drugs. So here at the end, this is the end of part 1, and part 2 we're going to get into some functional, like how do we look at heartburn and GERD functionally, how do we treat it functionally, and then also we'll talk about how do you wean people off of these
Good.
PPIs and H2 blockers. But I just want to sum up that these PPIs, the way that they work, the H2 blockers, PPIs, the way that they work is they decrease symptoms, right? So you don't have that esophageal irritation, because any little bit of acid in an inflamed esophagus can make you think you're dying.
Mhm.
Okay. So because they completely block the acid, they take the symptoms away, but they also remove all of the body's ability to digest food properly.
Right.
Okay. And you lose the protective mechanism of having all that acid in your gut.
Yep.
And then that can either cause or exacerbate this low acid. We get low digestion, which leads to low motility, right? Which is constipation. This can lead to anemia, SIBO, other nutrient deficiencies, osteoporosis, cardiovascular disease, all those things we talked about, dementia, and rebound when you try to withdraw the agent. Okay. So I know that's kind of a cliffhanger, and yeah, we're leaving you hanging. So it was
But
just going to be way
I
too
hope that
long.
people, that
Hmm.
do listen to this episode realize, "Oh, crap, like, I definitely need to listen to part 2 because,
Yeah.
um, I need to know how to treat this functionally because I definitely don't want these side effects of, these drugs."
Oh, for
Um,
sure.
so, you had mentioned, like, there is a time and place for these H2 and
Yep.
PPIs.
Yep. There
What
is.
would you say would be your reasoning to use them?
Well, so there are, like, for instance, when someone is in a hospital, there's a phenomenon called a stress ulcer. And so when someone is critically ill, often we will put them on a PPI in the
Mhm,
hospital and potentially even send them home with one.
mhm,
And the reason is because, um, once you get a hole, which that's what an ulceration is, it's a hole, you don't want acid continually washing over it. It's a it's making the best of a bad situation. So when people are critically ill, yes, we will block some acid. All right. Um, Also, there are there are times when I will use H2 blockers in people that have exacerbations of something like a mast cell activation. Okay, so we're seeing more and more and more people with variations of mast cell activation syndrome. Um, and these folks are really, really intensely reactive to lots of different things. And so while we're figuring things out, they are experiencing these massive histamine overloads every single day. And so, in order to calm the fires, sometimes I will employ the use of a short term, very short term H2 blocker along with a lot of other things to, because remember, H stands for histamine, right? So there is a histamine component to the acid in the gut. It's not H1, which is a histamine that causes you know, all the secretions that we see from the eyes to the nose, to the throat. This is a histamine too, and I want to block that too. So yeah, there are clinical applications for these sometimes, but they're very specific, and they're also very short term.
mm, okay. and then there is a process of get them off of it.
Oh, yeah.
This is not something that
Yeah,
you keep on.
when you're doing a 2-week course of something, the process is just stop.
Right.
There's no weeding process. It's just use this for 2 weeks and then you're done.
Okay.
Period.
Yeah.
So yeah, there are clinical applications where you may it's just going to be case dependent and provider dependent, and you might find that you use them for a little bit longer. You might find them that you can get them off of them in a little bit shorter period of time, but people really cannot be on these things for years and years and years and years without major repercussions.
Right. Well, this has been fascinating. I know we've touched on PPIs on our cognitive health, so please go back and listen to those episodes. They
Hmm.
were a wealth of knowledge on the cognitive component of
Yeah,
some
I
of
think
these
there's like
drugs.
4 episodes on that or something
Yeah,
crazy.
we
Yeah.
we we went deep dive on that. It was really awesome. So definitely go back to those. I'll link those in the show notes for you for easy access. But
Hmm.
please definitely turn on the notification for our next episode that will drop the week after
Oh,
this one does.
can I just say,
What?
I'm sorry. Um, as I was drinking my coffee, then I was thinking I need to brush my teeth because they're probably brown because of the coffee. And then I thought, teeth, enamel. Oh my gosh, I didn't even mention the dental implications of this. So please
Oh my gosh.
tuck that away. I missed that completely in my outline. Sorry, guys.
Oh,
Yeah, so dental implications are absolutely huge when it comes to just that erosion of enamel and a heartburn when you're having backwash into your
okay.
mouth. Yeah, so anyway, it's all bad. It's all bad. Get
Uh,
it treated.
yeah. Are we gonna talk about
Mm.
that a little bit more next time,
Oh, I
or?
don't think so.
Okay.
I think that's all people know.
Okay.
It's just yeah, it's just bad all the way around.
Yeah. So if you know somebody or maybe yourself that are on these drugs and you're like, holy crap, I need to figure out how to get off these. It's been a long
Hmm.
time that I've been on them. Definitely tune in to the next episode when Andrea goes into how to wean off of these safely. Because if you have been on them more than the 2 weeks that it
Hmm.
is prescribed, then it sounds like we need to have an action plan and not just cold turkey cut
Absolutely.
off. So I know many people that are taking these drugs. I will be sharing this episode with them, hopefully that they will listen. And, in everything that we do, and I think you did a great job, Andrea, of saying there is a time and place for these
Hmm.
medicines, but let's also figure out the reason, the root cause of why we are having these symptoms of heartburn, and
Yeah.
get down to the nitty gritty and figuring out like what do we need to change and what do we need to implicate into our lifestyle, which
Hmm.
I'm excited for the next episode to deep dive into that. If you found this episode or any of the other episodes that you have listened to helpful, the biggest compliment that we can receive is one, subscribing to our podcast, and then two, sharing it with your friends and family. So if you do that, please let us know. We would love to hear from you, whether that's through the social media outlets of tagging us in your story of sharing an episode, or just even emailing us. We would love to hear from you, and maybe even things that you've listened to on these episodes that you are now implementing into your life that
Hmm.
has made a big positive difference. We would love to hear that. So, as always, we thank you so much for listening, and we will catch you on the next episode.
Bye. The content provided in the AA podcast is intended for informational and educational purposes only. The podcast is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The information and opinions expressed in this podcast are solely those of the individuals involved and do not constitute medical advice.